Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and the Gynecology, Faculty of Medicine, Mansoura University. The title of my lecture today is Retained Placenta. Retained placenta is an important subject in obstetrics, and we wanted to discuss today the physiology of third stage of labor, the definition and the prevalence of retained placenta, the risk factors, the causes of retained placenta, clinical picture and the complication and the management of retained placenta, diagnosis and management of placenta accreta spectrum. Okay, what is the third stage of labor? Third stage of labor start after delivery of the fetus and the end with the delivery of the placenta and its attached membranes. As you see in the picture, this is a placenta and part of the umbilical cord. Normally, the placenta is delivered within 5 to 15 minutes. If 30 minutes have passed without delivery of the placenta, we call it retained placenta. However, in second trimester, it may take longer time to be delivered. It takes about 60 minutes, maybe reaching up to 60 minutes in second trimester, while more than 30 minutes in third trimester for delivery of the placenta is called retained placenta. What are the phases of third stage of labor? Latent phase, contraction phase, detachment phase, and expulsion phase. In latent phase, all the myometrium contract except the portion beneath the placenta, while in contraction phase, the retroplacental myometrium contracts. Detachment phase occurs with the horizontal shear on the maternal surface of the placenta, causing it to detach. While in expulsion phase, myometrial contraction expels the detached placenta from the uterus. The methods of separation of the placenta is two methods or mechanisms. Schultz mechanism, 85% of cases, the separation of the placenta occur at the center, so the placenta will be delivered as an inverted umbrella as you see in this picture. While the other method is called Duncan method, constitutes 15% of the cases, separation occur at the edges and associated with more bleeding and more occurrence of remnants of the placenta inside the uterus. The lines of management of placenta is two lines, physiological or expectant management and the active management. About physiological or expectant management, we palpate the abdomen and we make sure that the uterus is contracted. And notice the signs of placental separation and descent like gush of blood and the lengthening of the cord, and the uterus becomes more globular and the suprapubic bulge. Hold and inspect the placenta between two hands and rule the placenta to deliver the membranes, and inspect placenta for any absent cotyledons and the membrane for any absent part of the membranes. So this is the physiological or expectant management. While in active management, we give oxytocin infusion, slowly intravenous or intramuscular 5 to 10 international unit with the delivery of the anterior shoulder or after delivery of the baby. Or we can give ergometrin 0.5 milligrams slowly intravenous or intramuscular, but oxytocin is the best choice for the management. Clamping of the cord early after giving the uterotonic, control the cord traction, what is called Branded Andrews maneuver. As you see in this picture, we do gentle cord traction during uterine contraction, and at the same time the other hand do pushing for the body of the uterus and fundus upwards. Okay, this is called controlled cord traction. What about the retained placenta? It is a failure of placental delivery within 30 minutes after delivery of the fetus, its prevalence about 1.5 to 2.7%. The risk factor include preterm gestational age, which is the most common risk factor, stillbirth, maternal age above 30 years, use of ergometrin, uterine abnormalities, defective placental implantation, filamentous cord insertion, previous retained placenta. Causes of retained placenta: four main causes. Uterine atony is the commonest one. Adherent or invading placenta like accreta and Crede per caught or trapping of the placenta by the constriction ring or contracted cervix. The placenta here is separated but cannot pass through the cervix to the vagina to outside because of constriction caused by the constriction ring, or by contracted cervix. Or it may be due to rupture uterus and escape of the placenta to the abdomen. The clinical picture includes bleeding if part or all the placenta is separated or partially separated. In cases of uterine atony, the uterus is felt by abdominal examination as large, soft, and flabby. Vaginal examination may detect contracted cervix, or constriction ring, or placental adhesion, or ruptured uterus. The complications include postpartum hemorrhage, shock, maternal mortality, purpular sepsis, subinvoluted uterus, and hysterectomy as a line of treatment for this emergency case. The management of retained placenta include some prerequisites like anesthesia should be ready, anesthetist, insertion of large bore intravenous cannula, blood transfusion bank should be available, and blood units and cross-matched blood should be available. We insert urinary Foley's catheter. Then we are going to treat according to the etiology. If it is atony or constriction ring or placental adhesions or uterine rupture. In case of uterine atony, we do fundal massage and we do intravenous saline, 1 liter of saline with oxytocin 20 unit infusion, 60 drops per minute to cause uterine contraction. Also, we may give intravenous saline with prostaglandin F2 alpha infusion to decrease the bleeding occur with retained part of the placenta and help also uterine contraction to separate the placenta. Branded Andrews maneuver as before, we do parental cord traction during uterine contraction. At the same time, by the other hand, we do pushing to the uterus upward. Another line of treatment, if the above failed, we can do umbilical vein injection with saline and the oxytocin. Here we deliver the oxytocin to the placental bed, which causes uterine contraction. Lastly, if all the above failed, we do manual removal under anesthesia. In case of constriction ring or contracted cervix, we administrate nitroglycerin in the form of spray, 2 spray, 400 microgram per spray, or intravenous 50 microgram dose, or sublingual 0.6 to 1 milligram dose. In case of placental adhesions and invasion, we do hysterectomy is the definite line of treatment in case of placental invasion to the muscle wall of the uterus. While there is another conservative surgical treatment for some patients who want to keep the uterus. The fourth main cause is uterine rupture. In case of uterine rupture, we should do emergency laparotomy and extraction of the placenta from the abdomen, and then either repair of the uterus or do hysterectomy. This picture shows you how to do manual removal of the placenta Under anesthesia, we introduce our hand inside the uterine cavity, reaching the edge of the placenta. Try by shearing movement to separate the placenta partially till you reach the whole placenta separation, as in this picture and this picture. Here, the whole placenta is separated and we get it out. Another method for delivery of retained placenta is called the Crede maneuver, which is not done in modern obstetrics nowadays. We first start by empty the bladder, then grasp the fundus with 4 fingers, as you see in the picture here, behind the fundus of the uterus and the thumb in front. And then we squeeze the placenta and then push the fundus downward and backward to expel the placenta. And here the Crede maneuver and the modified one, and you can see the difference between both. It is not done nowadays because it is Shuki maneuver and it needs general anesthesia. Also, it is not suitable for obese patient. Also, it may be complicated by uterine inversion. Placenta accreta spectrum or placental adhesions and invasions. The definition of placenta accreta spectrum is a clinical condition in which a part of the placenta or the entire placenta invades and is inseparable from the uterine wall. 3 degrees, accreta, increta, percreta. The incidence of placenta accreta is increasing with years. For example, it was 1 in 2,500 deliveries in 1980. Then in 2002, it becomes 1 in 533. While in 2016, it is 1 in 272. As you see, this is the 3 types of placenta adhesions: placenta accreta, adhesion to the superficial muscle layer; increta, invasion of the muscle wall of the uterus; percreta, this is the increta, this is the percreta, invasion of the peritoneum and the nearby organs like bladder. So this is accreta, this is increta, this is percreta, and this is normal placenta from the other picture. FIGO classification of a placenta accreta spectrum in 2019 into 3 grades. Grade 1, abnormally adherent placenta attached directly to the surface of the middle layer of the uterine wall, which is the myometrium, without invading it. While in grade 2, abnormally invasive placenta, invasion into the myometrium. While in grade 3, abnormally invasive placenta, invasion may reach surrounding pelvic tissue, vessels, and organs. The diagnosis is very important in this case, and it is very important to predict the case before delivery and not be surprised during labor. The value of making diagnosis of placenta accreta before delivery is that it allows for multidisciplinary planning in an attempt to minimize potential maternal or neonatal morbidity and mortality. Diagnosis by risk factor assessment, by ultrasound, by color Doppler, and the MRI. About the risk factor, which is very important to be known, previous cesarean section is the commonest one, and with increased number of cesarean, the risk is increased also. Placenta previa, previous myomectomy, previous uterine rupture, Asherman syndrome, submucous myoma, maternal age of 36 years and older, and the endometritis. Ultrasound of the placenta accreta include loss of retroplacental hypoechoic zone, as you see in this picture, progressive thinning of the retroplacental hypoechoic zone, presence of multiple placental lakes, Swiss cheese appearance, thinning of the uterine serosa, bladder wall complex. As this in this picture, this is the bladder, this is the head of the fetus, and this is the placenta. As you see, the wall of the uterus is very thin and the placenta reaching the bladder here. Color Doppler signs of placenta accreta include dilated vascular channels, irregular vascular lakes with focal lacunar flow, hypervascularity linking the placenta to bladder, as you see in the picture. This is the bladder, this is the placenta, this is the hypervascularity. Dilated vascular channel with pulse-style venous flow over the cervix. Magnetic resonance imaging is very important also, and the diagnostic for placenta previa, but it is expensive and they need an expertise person. And the comparable diagnostic accuracy of MRI and ultrasonography for placenta accreta was observed by many users. This is the MRI and this is the placenta accreta, and this is reaching the bladder wall. Treatment delivery should be performed in tertiary center by an experienced obstetric team and multidisciplinary team that include obstetric surgeon with other surgical specialists such as the urologist, general surgeon, and the gynecologic oncologist if necessary. As you see, the bulging here in the lower uterine segment, this is for placenta accreta. And the accreta. If reaching the bladder and the peritoneum, it's called percreta. Treatment, if we are doing vaginal delivery and we're surprised by the placenta accreta spectrum, we do laparotomy and hysterectomy is the definitive line of treatment. However, if we are doing cesarean section and if we are predicting or diagnosing during pregnancy, we are doing cesarean hysterectomy. This is the definitive line of treatment. As in this picture, this is hysterectomy, and this is a placenta percreta. If the patient wanted to keep the uterus and the condition is not severe, it is grade 1, and the patient didn't complete her family, and we can try the conservative treatment. Either we leave the placenta inside and for spontaneous resorption, plus or minus methotrexate may be given or not, with uterine artery ligation and uterine artery embolization or internal area artery ligation. But the risk here is there is high possibility of infection and septicemia. Also, there is high risk for DIC and coagulopathy. So it is something also dangerous. Or another method is the excision of focal myometrium with the underlying placenta. First, we dissect the bladder downward beneath the cervix, then upper segment incision to deliver the fetus above the site of the placenta, then deliver the baby, then do bilateral uterine artery ligation, then elliptical incision to involve the placenta, and this focal part of placenta which invade the muscle or attach it to the muscle wall of the uterus, this focal part will be excised, then suture the muscle wall and do uterine reconstruction. Lastly, do bilateral internal iliac artery ligation. This is the conservative surgical treatment with the excision of focal myometrium with the underlying placenta. In summary, today we covered the physiology of third stage of labor, the definition and the prevalence of retained placenta and its risk factors, and the causes and the clinical picture and the complication of retained placenta. Then we went through the retained placenta management, and we said the management will depend on the cause. Is it atonic uterus or due to constriction ring or contracted cervix or due to rupture uterus or due to placental adhesion or placenta accreta spectrum, and then we went through the diagnosis and the management of placenta accreta spectrum. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.